Okay, well, hello everyone. I'd like to welcome you all. I'm Megan Cashwell. I'm the curator of historical collections at the Claude Moore Health Sciences Library. As you know, we intended to have a hybrid format today with the lecture taking place in our reading room. The weather had other plans, and we appreciate your flexibility. We are recording today's lecture, and it will be posted to the UVA Center for Health, Humanities, and Ethics YouTube channel, and it will be posted there at a later date. We ask that you keep your microphones muted throughout the talk. We will hold all questions until the end. Please enter your questions into the chat and we will address them in order. We are thrilled to have Professor Richard Mizelle from the University of Houston join us today. Professor Mizelle's talk is a part of the History of the Health Sciences lecture series, which is a component of the Medical Center Hour at the Center for Health, Humanities, and Ethics. For many years, Historical Collections has sponsored this biannual lecture in collaboration with the Center for Health, Humanities, and Ethics, as well as the Eleanor Crowder Bjorn Center for Nursing Historical Inquiry. Historical Collections is the official repository of this lecture series, as well as the Medical Center Hour in general. Before we begin, I'd like to take a moment to acknowledge several individuals who have played key roles in coordinating this event. First, I want to express my appreciation to the faculty and staff at the Center for Health, Humanities, and Ethics, including Dr. Justin Mutter, the director of the center, Dr. Margaret Hayden, Professor Marcia Childress, and Charlene Kaufman. I'd also like to recognize Professor Dominique Tobel, director of the Bjorn Center, for her collaboration and for extending the invitation to Professor Mizelle. Finally, a heartfelt thanks to my colleagues at the Health Sciences Library who made time in their busy schedules to support the lecture in various ways. Amanda Greenwood, Therese Anderson, Stephanie Freeman, Anson Parker, and Louis Savarese. Though our library director, Bart Reagan, is unable to join us, I would like to convey my gratitude to him as well. Slide here. In support of improving patient care, UVA Health Continuing Education is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. No one in a position to control the content of this educational activity has disclosed a relevant financial interest or relationship with any ineligible companies. If you are claiming credit for attending this lecture, please note the instructions on the slide and the ones that follow. I would encourage you to take a screen grab or photo of this information for future reference. And if you have any questions, please contact Charlene Kaufman.
Great. My name is Dominique Tobel, and it's my tremendous pleasure that I introduce today's speaker, Dr. Richard McKinley Mizelle Jr. Dr. Mizelle is Associate Professor of History at the University of Houston and co-editor of the Environmental History's Future series at the University of Oklahoma Press. His research, writing, and lecturing focuses on the history of race and healthcare politics, chronic disease, environmental health, and the historical connections between gender, identity, and ethnicity in medicine. Dr. Mizelle is the author of several books, including Backwater Blues, The Mississippi Flood of 1927 in the African American Imagination, and co-editor of Resilience and Opportunity, Lessons from the U.S. Gulf Coast After Katrina and Rita. And his latest book, Running Sugar, Diabetes, and the Politics of Race and Difference, will soon be published by the University of North Carolina Press. Dr. Mizelle's work has also appeared in a wide range of academic journals and publications, and I'll just include a couple here, including The Lancet, the New England Journal of Medicine, and the Los Angeles Review of Books. His research has also been quoted in the Washington Post, ProPublica, Kaiser Health News, the New York Times, and New Yorker Magazine. And he's appeared and consulted on numerous local and national podcasts, including NPR's Throughline and Floodlines, which was an award-winning podcast on Hurricane Katrina produced by The Atlantic magazine. I'm really delighted that Dr. Mizelle is speaking with us today, and he's going to talk about diabetes and the politics of difference. Over to you, Dr. Mizelle.
Thank you. Thank you, Professor Tobel. First, let me thank you for the wonderful invitation. Thank Megan Cashwell and Justin Mutter for the invite. Again, my apologies for not being able to make it there in person. I'm looking out the window now and it's starting to come down a little bit, but the weather had some different plans. But I'm glad to be here with you in this format. As Professor Tobel just said, I am completing a book on the history of race and diabetes, tentatively titled Running Sugar, Diabetes and the Politics of Race and Difference. It's important to say tentative title because this can always change, right? But I am excited to be at this particular moment in the writing process. I have just to be very forthcoming, drafted 4 out of the 6 chapters of the manuscript. And which means that I'm at a very particular moment, a very interesting moment in the trajectory of this project. I know what this project is about, but perhaps just as important, I know what it's not about. And I'm sort of very pointed, or becoming more pointed in how I'm thinking about some of these ideas. While at the same time, whenever I talk or whenever I'm having general conversations, in some ways, the entire book is sort of fomenting in my imagination. So I'll try to really narrow it down for this particular conversation. I want to be, just in this opening section, sort of be forthright about, this project and where, some of these ideas are coming from. I rely on traditional archives, historical archives in university, federal, state, and local, but also, city records and public health records, census statistics, manuscript collections, interviews, oral history, historical fiction, medical fiction, which was part of my first book, but also physician, patient records, and nursing records, right? And one of the arguments I make in this book is that many Black people throughout the 20th century were much more likely to encounter a nurse before a physician. And I lean on what some of my scholars have written about the possibilities and perils of Black survival and those individuals who were put into place or who mobilized to relieve Black suffering. And that included not only physicians, but also nurses, dietitians, pharmacists, social workers, and other professionals. And so I see my work as helping to push beyond this narrative of white male physicians as the sole arbiter of knowledge or medical information in the historical past. So these aren't the only themes of my book, but these are some of the major themes as I sort of start with this sort of broad view and then sort of narrow down to a particular moment. The unmaking of knowledge, right? These first 2 chapters really sort of deal with engage with a lot of scholarship that revolves around so-called Black immunity to disease, to yellow fever, to heart disease, to cancer, and this question that certain bodies are susceptible to certain diseases. There's, of course, been a lot of ink spilled on some of these conversations around who suffers or who is susceptible, which groups of individuals are susceptible to certain diseases. Part of the argument of diabetes in the early 20th century, which many of you know, is that diabetes was constructed as a disease of Jewish identity and whiteness, and that Black bodies were biologically incompatible with diabetes or incapable of suffering from diabetes. That was the main argument. My argument is not so much that Black people suffer from diabetes too. That much is obvious in the historical record. But really sort of thinking about what is the project of racial making around why these narratives were created. And so I sort of compare these narratives of ignorance making and agnotology that are different, but also in many ways similar to conversations around the tobacco industry, but also lead poisoning as well. The Great Migration, there was a really interesting, important narrative around migration. I think many scholars, myself, Sam Roberts, Amina Shakir, are really starting to think about this question of health and politics and migration. And that along with sort of escaping sharecropping economics and other issues, questions of health, trying to avoid chronic disease or epidemic, or in the process of trying to gain treatment for chronic disease, is part of the reason why many individuals sort of migrated to different parts of the world. But also really thinking about this concept of extinction thesis, which many scientists pushed in the early 20th century, arguing that Black bodies were incompatible with northern landscapes. And when they moved to the north, they became sick and ill from diabetes, from cancer, from other chronic diseases. So I conceptualized those narratives and placed them in broad historical perspective, but also Black responses and countering of those particular narratives. There's one particular moment in which I sort of talk about sort of physicians in Baltimore who write of sort of increasing diabetes among sort of migrants, and they're blaming sort of migrants coming from the South as raising the levels of diabetes in Baltimore. Even though the South is what, like 45 minutes away, right? So it's these sort of interesting questions of region, right? And sugar diabetes, that term is sort of used to, as a way of me sort of thinking about not only the medical, but the social and cultural sort of ways of knowing around this particular disease. The title of the book comes from a memoir in which a person talks about his father-in-law who had diabetes, and he sort of tells this story, which is sort of, which would be uh, not so dissimilar from other stories that people sort of hear. It's like people would ask, well, how are you doing today? And he would say, well, I'm doing okay, but my sugar is running a little bit, or I'm running a little sweet, or I'm sweet today, right? So these sort of cultural sort of euphemisms for what diabetes meant and means to different people at different times is part of this narrative. Medical civil rights, I really sort of, hinge on that particular moment in the 1960s and 1970s when local organizations, community groups, Black Panther Party, but also other organizations developed community clinics that were staffed not just by physicians, but by dentists, by obstetricians, by dietitians, all in a way to help alleviate chronic disease, but also alleviate diabetes. Disability complications, and this is a moment in which sort of talking in public sort of really helps to shape some of your narratives. I was really sort of pushed on this narrative of disability and thinking about the ways in which diabetes compared with, for example, epilepsy and other forms of disability. And as it turns out, diabetes and epilepsy have some similarities. Both groups were prevented from getting driver's license until well into the 1960s. There were these moments of fear that sort of having this condition would prevent you from being able to complete tasks, from being able to work in certain job industries. So these questions of disability are important for my narrative as well. But then also health passing, sort of leaning on the long Black tradition of passing within African-American literature. What does it mean to not want to tell someone of your condition, but similar to a Black person passing for white, for instance? How is this sort of narrative of passing, how is your condition disclosed to individuals, whether it's in the form of not being able to eat what other individuals are eating at a certain particular time, of having to remove yourself to inject insulin. These narratives have particular resonance throughout the 20th century. But then also eugenics and pampered favored class, which is a reference to World War II, when many soldiers with diabetes were prevented from entering the war, but also these narratives that eugenics, that diabetes was a family trait, and that many individuals were prevented or suggested to not marry an individual with diabetes to prevent this stain or this taint from entering into the bloodline. And then along with my first book, I've done quite a bit on questions of archive and narratives of archival suspicion. One of the sort of, questions or points that have always been raised about my particular book is that, well, I believe some of the things you're saying are correct or accurate, but I don't think you can prove it. right? Which is sort of a point that many of us who do work in this particular time period often are confronted with. And my counter to that is you have to look in a different way. You have to change your vantage point. There are moments in which diabetes does not show up in the archive under that particular term in Black newspapers or other sort of moments, but it might show up as obesity, right? So there might be these conversations around obesity in the 1920s and 1930s in certain newspapers. And under that category of obesity, you might see a discussion of diabetes. And so these moments are important, along with the importance of Black newspapers as a way of sort of, which many people don't necessarily engage in the early 20th century. Black newspapers, I argue, are very important. And so these particular moments, I think, are really fascinating for us to counter the archive and sort of create a narrative that's inclusive of everyone. So for this talk today, I want to narrow down on a particular slice of what I'm thinking about, particularly this slice of difference between two pieces of legislation, the National Diabetes Commission and the Heckler Report. And so the majority of this talk will then sort of move between the mid-1970s and the mid-1980s, just to make a few specific points of how I'm thinking about this concept of difference, but also how I'm thinking about this concept of difference between, how we understand diabetes over time, right? So the terminology of diabetes went through many iterations over the 20th century that included designations of thin and obese, juvenile and adult onset diabetes, which is to say there was no such thing as type 1 or type 2 diabetes in 1900, right? Those particular designations did not come about until much later. By 1979, scientists and physicians pushed to further distinguish between the different biological origins and groupings of the disease, creating the distinct categories of insulin-dependent mellitus diabetes and non-insulin-dependent diabetes. IDDM was mostly tied to what was previously known as juvenile diabetes, or what we might now consider type 1, and NIDDM was considered the equivalent of adult onset diabetes, what we might now consider type 2. Scientists hope this newly formed classification system would eliminate ambiguity of diagnosis and treatment, while also sending a clear signal of what they perceived as the different biological and social origins of IDDM and NIDDM. Sorry for so many of the acronyms. The former was a biological and blameless misfiring of the body's pancreas that resulted in disease, many argued. The latter, on the other hand, was a social illness created by overeating, refusal to exercise, and indulgence. The messages of difference that had been subtle were now becoming more explicitly racialized. IDDM was considered the rarer form and increasingly defined more explicitly as a disease primarily of white people. NIDDM was by far the more common form of the disease and was being redefined as primarily a disease of minority groups. Importantly, IDDM was redefined as an autoimmune disease by the mid to late 1970s. The rise of scientific awareness around Addison's disease and Hashimoto's disease in the 1950s created an environment where other autoimmune diseases were slowly made visible. By the 1970s, diabetes experts suggested that one form of the disease, juvenile onset, also had an autoimmune origin. The concept of autoimmunity was still in a relative infancy, yet diabetes was instrumental in helping shape other autoimmune diseases as devoid of moral blame. As experts suggested that the autoimmune form of diabetes overwhelmingly impacted those who were thin, young, and white, such narratives reinforced the blameless narrative of autoimmune disease. Though many statistics suggested whites were more prone to autoimmune diabetes, it was far from non-existent in Black and other groups. The emergence of autoimmune diabetes, or IDDM, created the categories of good and bad diabetes that we often hear. A new chasm was created in the minds of scientists and patients that began the process of separating diabetes into different diseases that demanded different resources and attention, and importantly, reshaped narratives of racial susceptibility. Whatever remained of an imagined community, in the words of Benedict Anderson, was shattered. There could be no singular research focus or search for a cure. They were becoming two different diseases, like diabetes and cancer. Dangers associated with one type might mean little to those with the other type, with the result being a hardening of racial and class attitudes and moral philosophy toward the cause of disease. Obesity, on the other hand, by the 1970s, was becoming the watchword for inferior genes, overindulgence, and immorality, and a new identity known as metabolic disease. Representing the constellation of specific clinical and laboratory measurements on the molecular level, elevated blood sugar, cholesterol, blood pressure, and weight, metabolic syndrome was not so much a defined or recognizable disease as what sociologist Anthony Ryan Hatch has called a disease in the making. Elevated levels of these four key measurements were considered risk factors for diabetes, stroke, heart disease, and other conditions. The language and discourse of overeating and obesity was shifted from early 20th century descriptions by Elliot Joslin of the fat Jew. His words, where fatness or corpulence was once considered a sign of wealth and creativity of Jews and whites with diabetes earlier in the century, by the 1970s, obesity was increasingly employed to define the poverty, willful overconsumption of food, biological inferiority, and blameworthy neglect of disease associated with Black and Asian groups, indigenous populations, and Mexican Americans. So it's at this moment, in 1974, when Congress passes legislation to create the National Commission on Diabetes, which for the first time, in a federal public perspective, decreed diabetes as a major national health issue. Now, there are a couple of things that are really interesting to me about the National Commission on Diabetes. Part of the importance was that it really highlighted the need for sort of training centers, but also elevated the importance of physicians, nurses, and dietitians in dealing with diabetes. There was a 17-person commission that would go out and do much of the testimony for this commission. And this testimony would come from various individuals, people, organizations, physicians, nurses, patients, but also other professionals. And it really sort of highlighted or attempted to highlight for a general public the danger or the problem of diabetes. But importantly, it highlighted really for the first time this chasm between the American Diabetes Association and at the time, the Juvenile Diabetes Foundation. The American Diabetes Association, of course, was founded in 1940, primarily as a professional organization of physicians, not so much as a patient advocacy organization, unlike the older British diabetes organization. The JDF was founded in 1970 by Lee Ducott, who was the mother of a child with diabetes. And so the JDF, from its outset, considered itself to be a patient advocacy organization, mostly of parents, but also of individuals who were growing older, but primarily individuals with insulin-dependent diabetes. But what you see in this commission, and I must admit, when I first started this commission, looking into this commission, I thought it was going to be a bunch of humdrum, just run-of-the-mill stuff. But there was really some really interesting sort of narratives occurring in the background. But this chasm between the ADA and the JDF was really interesting, right? So the ADA testimony really pushed for education for these training centers, for more brick and mortar establishments, for clinics, for individuals to come and receive treatment, for physicians, for dietitians to help educate the broader population about the dangers of diabetes. Parents who participated in the commission were primarily against this, right? They argued much more for research dollars for a cure. So it really was this sort of dichotomy between education and what other individuals thought was the need for a cure. Many argued that there was no need for more brick and mortar establishments, that the primary focus of Congress was to find the research money to alleviate this particular disease. But by particular, they meant insulin-dependent diabetes. So for the first time, you start to see this narrative of true diabetes, of loose versus tight control diabetes, right? True diabetes being what we now think of type 1. Loose diabetes, what we might now think of as type 2. Right, so you see this chasm and this racialization, but it's also based on class, right? So this class is creating this sort of racialization is creating this narrative of class. And Thomas Kogel, who was president of the Washington D.C. JDF chapter, perhaps wrote it most succinctly. He wrote, "The single overriding most important problem in diabetes today is the longstanding neglect of research. Not education, not training, not publications, not screening programs, but research." So it was clear that research should be the commission's number one and perhaps only priority for Kugel. And he, in fact, doubled down on this point, saying, quote, "Should you have any doubt as to the meaning of that statement, let me say as clearly as I know how that this also means that training, publications, construction or staffing of diabetes centers other than research, screening programs, early detection, etc., are and should be other than the first priority." End quote. For Kugel, brick and mortar diabetes centers and clinics with a focus on treatment and education were a waste of resources. The other piece that was really interesting in this National Commission on Diabetes was this really interesting and fascinating conversation around food. Now, I'm not by training a food studies scholar, but I was fortunate enough to be pulled into an NEH grant several years ago on food history at the University of Houston. And so I really began thinking about some of these sort of broader conversations. And part of what nurses and dietitians in particular were highlighting in this commission report was that many of the food sheets were of westernized sort of foods or foods that would be recognizable to a Western diet. And while those foods might be healthy, there were other foods that were of a non-Western origin that could be used on a food exchange sheet as well. So basically what they were arguing, just to be succinct, is the decolonization of the diabetes food exchange sheet. To think about these foods that other individuals were eating in other parts of the country that might help alleviate or help individuals deal with the diabetes in their bodies. And that's an important sort of trajectory that I think you see in this commission. And, other individuals, other scientists, other researchers made similar points, right? Sort of thinking about East Asian and Asian groups and the consumption of curry leaves or lentils, black grains, and bamboo shoots as part of their staple diets. East Africans, maize, cabbage, turnips, and sweet potatoes. West Indian and Caribbean groups of cassava, guava, jackfruit, soursop, tamarind, ackee. Black people in the United States consumed many of these foods passed down through generations of ancestors of African and Caribbean origin. Yams, dates, peanuts, spinach, peas, sweet potatoes, onions, pineapples. These were all traditional foods of the diet that people consumed that were often not a part of these diabetes exchange sheets that were coming from some American Diabetes Association, but also local clinics. But beyond these foods, Eastern herbs and teas long used by groups to cure chronic diseases were also completely disregarded. And so this commission, I think, served an important moment in sort of thinking about some of these issues and questions. But one of the particular issues for the commission is that these testimonies were limited. It was very difficult for many individuals to get to these sites to offer their testimony that would make its way into these commission reports. This is a map of the sites where these commissions occurred. And if you look, of course, outside of Atlanta, the South seems to be a particular dearth space where individuals could go and offer their testimony. And so one of the individuals who was on this commission was Dorothea Emma Webb Puckett. She was the only Black person on the commission the only woman on the commission, and the only person who had diabetes on the commission. At the time, she was assistant professor of community health at Wayne State University. I think she was the first person to get a PhD in nursing from the University of Michigan. She was really young, only 28 years of age, and was on the scope and impact subcommittee, right? This is one of those moments where you're in the archive and you come across this and you're like, how did I miss this all of these years, right? Her story is really, really important for this narrative, right? So Puckett was diagnosed with juvenile diabetes at the age of 11 in Nashville, Tennessee. Her family was part of the Black middle-class community in the city, considered playfully as chubby by family and friends. Very quickly, her weight dropped from 130 to 80 pounds. An avid reader, her mother often consumed health-focused articles and opinion pieces in magazines and newspapers and immediately thought Dorothea must have diabetes. It was not an unknown disease for the family. Dorothea's grandmother and aunt had also been diagnosed with diabetes. She was immediately started on an insulin regimen at Vanderbilt University. Puckett was a disciplined and smart child, an honor roll student, played the piano, and considered exceptional by everyone in her circle. Not unlike most children, the demands of taking insulin and a restricted diet were overwhelming for her at times, once leading to her falling into a coma in high school. After this incident, Puckett and her family realized the dangers of poorly managed diabetes as life-threatening. Some of her friends asked if she really had the nerve to inject herself with insulin every morning. Some came to see for themselves. Her own experiences with diabetes shaped her research and advocacy around diabetes. She actually published a dissertation on siblings of individuals with diabetes and family dynamics. But as a member of the commission, Puckett pointed out the importance of communication between health providers and patients in a non-rushed fashion for physicians to think holistically about a person's background, life experience, family and support system, and social environment when treating diabetes. As important, Puckett was adamant that nurses, social workers, dietitians, and other health professionals, in addition to physicians should play an important role in diabetes care. She was concerned that too many Black minority elderly women and those with psychosocial issues and the socioeconomically poor with diabetes were long made invisible in public health work of researchers, and many would not have the resources to travel and provide testimony at the 7 appointed cities for the commission's work. So Puckett, along with a cadre of her colleagues with tape recorders in hand, went into these rural areas to conduct interviews that would become a part of the commission. These interviews, which are in many ways sort of separate in terms of where they're located in the archive, but part of the commission itself, many of these individuals were identified mostly through socioeconomic status, gender, and region, not really identified by race, although it seems clear that many of the interviewees were Black. Maybe one or two sort of disclosed directly that they're Black, but mostly, where they're from, sort of region, gender, and class status. But they were asked a number of questions that I found really interesting, which I also think is important for thinking about this sort of narrative of race and racial difference, but also this increasing chasm between what we now know as type 1 and type 2 diabetes, right? Asking the question of, did they understand why physicians wanted them to eat certain foods at certain times, why they needed to check urine when they first woke in the morning, why they needed to constantly check their feet and clip toenails to avoid infection. And importantly, was transportation an issue? How did they get to the clinic? There was one really telling story of a woman who took a 12-hour bus ride from a rural area to a clinic and arrived in the city of the clinic at 5 o'clock in the morning and had to wait several hours until the clinic opened, and then had to take the same bus back 12 hours. And if she missed that bus in the afternoon, then she might have to wait until the very next day before she would be able to travel back home. And she talked about the toll that took on her body, that in some ways, the travel to the clinic, as she said, was worse than the diabetes itself, that she would be in bed for 2 weeks after this travel to the clinic. These particular stories of one woman looking down and seeing blood in her slipper because she had stepped on a tack and noticed this blood and realized that she didn't have any feeling in her foot. So these particular narratives sort of highlight the dangers of diabetes, but also the difficulty that many individuals had accessing medical care. Quite a bit of information around amputations, gangrene, eye issues, food availability. One of the ways in which my book separates from other scholarship on the history of diabetes is my focus on the complications of diabetes, kidney failure, amputations in particular, but also disability related to sort of loss of eyesight. So these questions were important for me as I sort of thought about these issues, right? And as far as I know, I've gone back through every issue of the forecast, and I don't think I've missed any, but I could have. She was the first Black person to be featured in the Diabetes Forecast magazine, which was sort of a patient-oriented publication that many patients and physicians engaged with. So, one of the questions that I also sort of deal with, sort of moving beyond that particular moment, is this idea of the nutrition transition. One question I was often asked, or continue to be asked, really, is sort of what role does soul food play in diabetes? It's a question that I never particularly liked. And even before I really sort of began to think about these questions, I didn't like the question. Because soul food is in many ways a created term. It's a narrative that sort of emerges at a certain point, really around the 1960s and 1970s. It's not like people in the 1940s and 50s were saying, "Yeah, I'm going to eat soul food today," right? They were just eating dinner, right? Soul food is a moment that was sort of created much later, as Psyche Wilson Williams Forsythe describes. But there was a moment in which between 1975 and 1980 that obesity rates were on the rise among everyone, not just Black people eating soul food, right? Sort of obesity rates were rising among white people, among children, among groups all over the world. And this, of course, would become known as the nutrition transition between 1975 and 1980. Much of these changes, of course, had seeds during World War II, but also, as the sociologist Naya Quata writes, the second generation of fast food restaurants. And as I was telling people offline before we had this conversation, I don't really have much space to sort of talk about, much of anything else. And some of this narrative is a little new and probably will make its way into the epilogue. But the evolution of what Quata defines as the second generation of fast food restaurants, Church's and Kentucky Fried Chicken, Burger King, McDonald's, between the 1950s and the 1970s, really had an important impact on the rise of obesity rates and the rise of type 2 diabetes. And this is an important point as well, right? So even the evolution of McDonald's outside of the United States was important, right? McDonald's franchises began appearing in the 1970s in Japan and was the vision of Japanese businessman Den Fujita. In the 2000s, Fujita introduced the Mega Teriyaki, a sandwich with 2 pork patties, teriyaki sauce, and mayonnaise. The Mega Mac with 4 beef burgers, multiple slices of cheese, and dressing. As other scholars have written about quite a bit, Fujita suggested by the 1980s that fellow Japanese citizens should eat like Americans as a way to become westernized, suggesting that traditional Japanese diets made them weak and pale, and that a shift to a beef-based diet such as McDonald's would make Japanese consumers not only stronger, but also blonder, right? In 1987, Kentucky Fried Chicken opened near the infamous Tiananmen Square. And so the entrance of global fast food into China has met with disastrous public health consequences. And along with Mexico, China experienced a significant rise in obesity in the span of just 20 years. So I'll come back to that in a moment. But all of this then becomes important for this sort of moment between the National Diabetes Commission and the Heckler Report. Released in October of 1985, this massive 10-volume public document, known as the Heckler Report, was really the first time in which people have often defined race and diabetes, or the first moment in which many people say that the federal government actively sort of responds to this question of race and diabetes. But it appeared as really as an existing literature on health disparities, more so than original or innovative research. The overarching takeaway from the report was that minorities died at a consistently younger age and were unhealthier across the spectrum of diseases than white Americans. Much of the Heckler report regurgitated without criticism previously published research based on faulty or racially dubious research. The Heckler report is often considered the first moment in which the federal government began paying more attention to diabetes. Diabetes mortality among non-whites was double that of so-called whites, including indigenous groups, Hispanics, but also what they defined as African Americans. Asian Americans, the report suggested that they suffered disproportionately to non-whites, even though there was only brief discussions of diet were described in sections for Native Americans and Asian Americans, but devoid of broader political issues like the forced relocation of indigenous groups to reservations away from their traditional foods and habits. One of the sort of sections I've been working on most recently in this book is about Asian susceptibility, but also the rise of diabetes among Asian groups over the course of the last 50 years. And part of this revolves then around this idea of the model myth minority, and which had unintended consequences for Chinese and Japanese immigrants. So in the 1980s, while diabetes was still relatively rare among Asian groups in the US, the disease was rising across the globe for many Asian groups, the result of changing eating habits and rising obesity rates. For those immigrants remade as the model minority, their status in the US masked their growing experiences with diabetes and other diseases. The model minority trope was rife with stereotypes of the Chinese and Japanese as non-confrontational, demure, frugal, affluent, and westernized in thought. As the numbers of Chinese and Japanese immigration rose following the Hart-Celler Act of 1965, their presence within debates around public health and racial health disparities were left unacknowledged. Scientific research around the problem of diabetes focused overwhelmingly on Black and white people. Hispanics and indigenous groups in the 1980s and 1990s, comparatively little attention was directed on Asian, East Indian, and African groups. The pivot for the Japanese and Chinese model minority myth was that they were defined as possessing the laudable traits often associated with certain forms of diabetes. As IDDM was being reshaped racially as a disease of control and self-restraint that mostly impacted white people, and NIDDM as a disease of obesity, excess, immorality, and lack of control, the model minority trope came to embody larger notions of white self-control. Along with stereotypes that Asian groups were rarely obese and small in stature, the model minority myth uniquely racialized Asian bodies that made them both hypervisible within immigration policy and invisible within public health research. The intellectual and physical attributes used to construct them as the model minority would also serve to mask the slow expansion of diabetes among all Asian groups in the US for decades to come. So, my major point here is that the Heckler report was, as you might imagine, criticized on many fronts, but it also helped to mask many of the trajectories and statistics that other researchers were seeing, including a growing rate of diabetes among whites in Appalachia that my colleague Arlene Tuckman talks about and describes, but also of larger Asian groups. But also the growing rate of diabetes across the globe. Megan Vaughn has a really important, fascinating sort of essay on diabetes in the African context. So this particular moment of moving beyond these narratives become really important. And so it's in the aftermath of the Heckler report that you really start to see again, this sort of chasm within sort of diabetes types. And what we now know as type 1 and type 2 becomes really codified around 1995 as we move from NIDDM and IDDM to type 1 and type 2. But what you also see is this sort of again shattering of this imagined community, but much more of a concerted effort among those with type 1 diabetes to separate themselves from those with type 2 diabetes that I think emerges from the 1970s, emerges from the evolution of JDF into JDRF, but also this testimony and sort of how these questions around the Heckler report emerges. So, by the 21st century, you begin to see articles like this, right? Civil War, diabetes versus diabetes in the San Diego Union, but also this push to change the name and in particular separate themselves in terms of resources, in terms of the biological origins of the disease, but also the social origins of the disease between the two groups. And just recently, JDRF changed from JDRF to breakthrough type 1 diabetes. But the important point too is that type 1 diabetes is not just a white disease, and it has never been just a white disease. And I sort of narrate this through conversations around Dorothea Emma Webb Puckett, but also Eric Dolphy, who's a jazz musician who likely had type 1 diabetes and died in the mid 20th century. And you see this in the statistical reports where, in a report in 2020 wrote that there was a 30% increase in type 1 diabetes, but growing sharply among diverse populations. Type 1 cases among Black children increasing by 20%, among Spanish-speaking or Hispanic children by 20%, Asian Pacific Islander children 19%, and also continuing to increase among white children. And so these questions then become important for me in terms of how I sort of think about this project around these sort of continuation. What we do as historians, we provide snapshots of the historical past, but we also narrate a story across time, right? So in the early 20th century, I can sort of document sort of this sort of misdiagnosis of Black people with diabetes who were assumed to be immune to the disease to the mid 20th century, where there was sort of an assumption that they were suffering from non-insulin dependent diabetes, where they were really suffering from insulin dependent diabetes, to stories like this, where Kimberly Jarrett took her 15-month-old son to the hospital from the Mount Airy in Pennsylvania, and rushed her into the emergency room. And earlier that week, a pediatrician said that Jace's lethargy, her son, was from the flu, but he was drinking excessively, had excessive urination, but somehow did not check for diabetes. And this was the same, these are sort of stories that you sort of see and that I sort of tag and catalog and sort of place in historical perspective. What does misdiagnosis mean? Like, what does it mean to sort of see these signs of excessive urination, excessive thirst, all of the signs that someone might be suffering from diabetes, but then say that they're suffering from the flu, or signs that they might clearly be suffering from type 1 diabetes, but diagnose them as type 2 diabetes. And that was the case for a woman by the name of Kylene Redmond, who went into the urgent care many years ago. And, she was diagnosed immediately with type 2 diabetes. She was sort of urinating excessively, drinking excessively. In her words, she was overweight, but the urgent care physician just automatically assumed that she was type 2 diabetes because she was a Black woman. She had a family history of diabetes, but in hindsight, she writes and talks about, why they did not do an antibody test to see which type she was suffering from. And even when she would come back and she changed her diet and she did all of the things that they had asked her, she went into DKA, She continued to feel horrible for several months. She would go back and they would still say, well, you're just not doing enough. You're still suffering from type 2 diabetes. She actually happened to work in a hospital and she asked a colleague, about what was going on. Colleague tested her, and as it came back, she was actually type 1 diabetes. So, I talk about this sort of misdiagnosis of Black women and Black people, constantly, whether it's sort of lupus or fibroids, and sort of how these assumptions and these myths and these stereotypes sort of hinder appropriate or proper diagnosis, but also how they're historical in origin, right? So this sort of concept of a Black immunity to diabetes in the early 20th century has made its way through a weaving fashion to this concept of Black immunity to type 1 diabetes in the 21st century. And that's the historical moment that we're in. And that's the historical moment that I talk about and define when I talk about the politics of difference, and diabetes and the politics of difference and what we can do to change this. So I'll stop there. Went a little bit over time, but thank you so much.
Thanks, Rick. That was really wonderful and raises a lot of like critical questions, and kind of sheds really important light on the history of the racialization of diabetes. So everyone, the chat, if you have a question, please type it in the chat and I will read it out while folks are thinking about their questions. Rick, I was wondering if you could say if you're able to tell us a bit more about the nurses and dietitians who were calling for the decolonization of food exchange sheets in the 1970s, because that really struck me. And I don't often think of nurses who are overwhelmingly white, and not doing well with grappling with issues of racialization and racism in healthcare at that time. So, can you provide a bit more information about who they were calling for that decolonization?
Yeah, no, that's a good point. Much of the testimony in the National Diabetes Commission um, comes out of Texas, oddly enough, and particularly around the Austin, San Antonio area. I don't know the identity of some of the nurses, but I do know that a few of them, probably the majority of them, were Spanish-speaking nurses. So they were advocating for their own communities, and in places where they worked. And so no, that's a good point to make and sort of a description to make. But there was literature, coming out of the commission that really sort of spoke to me about other sort of literature that I was seeing in the archive that also sort of made similar points about diet, right? And, some of it was, kind of, well, these foods that we're eating here in the Western context are not good for our bodies. You have some of that. But most of it was just, well, there's a one-to-one, right? Don't eat bread, but eat this. Well, we cannot eat bread, but eat something that's in our community that's healthy too. And so I think these Spanish speaking nurses, I think were really at the forefront of sort of pushing that, at least on a federal level that I see in the commission.
Yeah, that's really great and really important and really kind of really striking. So thanks. Okay, we have a question in the chat. So thank you for the provocative talk. Question about the role you see for a patient education, public education about the social history of diabetes and the role of race and class in shaping patterns of disease. And this is from Dr. Hayden, who's a primary care doctor, and says that we think a lot about educating patients about foot care, diet, etc., but often don't have a framework for engaging with patients on these broader patterns. Are there examples of which ways have been tried to engage the public about this history, or particular ways you have seen providers engage with individual patients about this history as part of holistic diabetes care?
Could you say the middle part of that again? For some reason,
Sure. Yeah,
it's a little low.
this is coming from a primary care physician who is asking for who's talking about the frame. Often they don't have a framework for engaging with patients about broader patterns. And so,
Yeah.
do you have examples of the ways in which to engage the public about the history, or particular ways you have seen providers engage with individual patients thinking about the more holistic approach to diabetes care?
Yeah, I mean, I think that again, part of this conversation around sugar is people think that that's just, sweets, right? And it really includes sort of other aspects of what people consume, but also sort of the stress that you have in your life can have an impact, particularly on autoimmune diabetes, but also what we think about as type 2 diabetes as well. Um, but I think as a historian, I often think about sort of bias and what are the sort of implicit biases of sort of providers, but also how we can get physicians and nurses and health professionals to understand those particular biases and how they're sort of interacting with people. I've written quite a bit on sort of amputations, but also on sort of kidney failure. But I think one of the ways we also sort of think about these questions is through the foods that we eat, right? Sort of understanding the systemic structural barriers and what it takes for someone to eat healthy. And people have talked quite a bit about that, but in some ways we haven't, right? And so it really then becomes difficult for some individuals to eat healthy, and sort of understanding that and understanding the ways in which where they live can impact sort of how they access treatment. All of these things are important. I was giving a talk at Northwestern some years ago, and person was talking about PT deserts, right? Which I'm not sure I'd ever thought about a physical therapy desert, but in certain areas in Chicago, it can take someone 45 minutes to get to a physical therapist, which is important if you have complications to diabetes. And so I'm always thinking about these sort of broader structural barriers that are often left unsaid, and how we think about that in relation to not just diabetes, but also other forms of disease as well.
Yeah, thank you. Um, I oh, here we go. We have another question. Will your book speak to the impact of race-based estimated glomerular filtration rate measurements on the diagnosis and treatment of diabetes-associated kidney disease?
Um, that's a good question. Probably not. But I do have an essay that's coming out, it's actually just came out last or 2 weeks ago on racing chronic disease. I'm sorry, racing kidney failure. It's in a book published by Rachel Elder and Thomas Schlick through Edinburgh University Press. Both of them are at the University of Montreal. And in that particular essay, I talk about EGFR, the evolution of kidney failure, Seattle Artificial Kidney Center in Seattle in the 1960s and 1970s to the 1972 Dialysis Entitlement Act, and then to sort of these more recent conversations around EGFR and the push to end EGFR by certain hospitals and institutions. So um, I don't think I'm going to have space to talk about it necessarily in the book, but that's an important point. And yeah, I'm excited about that. I haven't actually seen it in print yet. I haven't gotten my advanced copy, but it is coming out in that essay collection, which I think is called Technology and Patient Identity.
Great, excellent. We have a comment from in the chat, and this is from Marsha Childress, who said this is such a fascinating and important project. And she recalls meeting you several years ago when your research was in its infancy, but is even then urgently compelling. And she notes that your examination of diabetes is especially illuminating as an example of how illness and the implications are bicultural as much social and cultural constructs as physiological phenomena. And thanks you for this fine work. And
Thank
I am noting that we're right at time, so I think that's a great kind of remark to end our discussion on. And I just want to thank you again, Rick. This is just such important work, and I imagine many of us will be excited to buy your book when it's done. And so, thank you for sharing your research with us and spending this time with us today.
Well, thank you so much. I appreciate it. Sorry for going over time a little bit.
Oh no,
It's I better gauge these things when I'm in person.
totally
Yeah.
understandable, and I think we all valued from the time you spent. So thank you.
Uh, Thank you. Thank you so much. I appreciate it.
I have so many questions for you, Rick. I wish we were. Well, I know we'll have some time tomorrow as well to chat, but yeah, just really fantastic and really I really appreciate your attention to the role of nurses in this history as well, and particularly in kind of pushing back against some of the harmful narratives.
Yeah. And thank you again, Marcia Churches. I appreciate that comment. And, Dorothea Emma Webb Puckett is really such a fascinating person, but she just kind of, for me, drops off the map. Like, I really can't find anything about her
Mhm.
beyond this moment. And, I haven't had too much time to look. And for all I know, she could still be alive. Like, I haven't found anything that she's dead, not no longer with us. But there's just not much. I've kind of come across a Jet magazine piece on her in the 1970s. I think I found a family member who still lives in Michigan, and I reached out to him, and he didn't respond, and that's okay too. I understand that, but I think when this project is over, I might try to do a little bit more. I've talked about her to Kylie Smith, and and maybe I might write something additional about her, and her life, and in this particular moment. Yeah.
Yeah, I hope you will. And I'm happy to talk offline about you because I've done some research at Wayne State looking at some of the nursing papers, but her name, I haven't seen her name, but I will dig through my notes to see if she is anywhere in my materials.
Yeah, I reached out to an archivist, and there was like one image of her, kind of a faculty image, and that's it. It's really, yeah. But yeah, she's such a fascinating person and fearless. Like, to be on that commission, with those, white men, and she's the only woman, only black woman, only person with diabetes, and pretty much she almost single-handedly demanded that they expand the interviews to deal with these things. And there's several moments in which I can tell that people interviewed are black, but they don't say so, right? And so I sort of, write that narrative as well. But that was a really powerful move on her part, and one that took a lot of nerve and a lot of heart.
Yeah, for sure.
Yeah.
Well, thanks, Rick. I know that we've got some other folks hanging out online, so I guess we should probably end this
Yeah.
end this
Thank you.
as much as I'm like, we'll have to find other opportunities to continue it. And thank you again. And obviously, you'll be joining us tomorrow with my students, and I'm grateful for that.
All right. Sounds good. Thank you so much. All right.
Thank
Let's see you
you.
tomorrow. Thanks, everyone. Appreciate
Thanks,
it.
bye.